with that, we now recognize Ms. Gay for 5 minutes to give an opening statement.
Chairman Dr. Joyce, Chairman Guthrie, Ranking Member Plouffe, Ranking Member Clark, members of the subcommittee, thank you for having me here today. My name is Jessica Gay. I'm currently the Vice President and co-founder of Integrity Advantage and the President of the Maryland chapter of Certified Fraud Examiners. For over 15 years, I've partnered with more than 60 payers across Medicare, Medicaid, FEHBP, commercial plans, CHIP programs, conducting fraud, waste, and abuse detection, analysis, and investigations. The healthcare industry is about $5.3 trillion spent in 2024, and we estimate as high as $500 billion of that is FWA. We process nearly 30 million claims a day across well over 1,000 payers with varying rules, coverage determinations, and data elements. Oversight of this magnitude is bound to need attention. FWA is not a victimless crime. Unnecessary services expose patients to real medical risk, while fraudulent billing drains resources intended for those who legitimately need it. Patient harm occurs through unnecessary or unsafe for the sake of reimbursement. Overall, patients suffer in reduced access. And we are the patients. The taxpayers are also the patients, in this scenario. Taxpayers, we're paying for it twice. We're paying for the FWA that is on top of the already big spend, as well as the rising costs for our individual health care. And the honest providers whose reputations suffer as fraud undermines the trust of our healthcare system. Common schemes in this area, some of which were already addressed, include applied behavioral analysis services. These are a huge issue across Medicaid fraud, and we see missing records completely, unqualified staff, billing that is inconsistent with authorizations, treatment plans that are not tailored to these members' needs, and excessive services. Non-emergency medical transportation continues to be an issue as well. We have trips to nowhere, inflated mileage, and upcoding to higher services. Home and community-based services also continue to be a big issue. We see falsified state authorizations, round-the-clock services for low acuity diagnoses, including hypertension, and billing for one-on-one when delivering care to many patients in one home. Laboratory services and genetic testing continue to be a problem. We mentioned skim substitutes, which is really a highly targeted area due to excessive units. I've seen payments for secondary payers up to $30,000 for one member, and that's after Medicare already paid their portion. DME continues to be an issue. These are not isolated issues to one state or one payer. They are discussed consistently across national platforms and anti-fraud forums. Of course, we have a lot of challenges in anything this big, and we could do better. Some of the things that I would recommend is a look at policy. I would invite fraud professionals to the table as we design policy and we think about benefit coverage. We have a different perspective. We tend to think about the holes as a fraud professional, but generally we see inadequate state, federal, and plan level policies that result in inconsistent and unenforceable coverage rules. We need to strengthen our frameworks with clear coverage guidelines and federal defaults in the event that states or plans lack sufficient definition. We need resources, and I'm not just talking people, whether that's people, process, technology. Things are changing and the fraudsters are winning. We need to keep up with that, and we need some collaboration there, and therefore efficiency between the state, the federal, the commercial players, whether that's through data and joint investigations. And for those that know me, I'm just bringing up data as the last point, but data is a big issue in healthcare fraud. We have complicated data and poor data criteria in general. It's very inconsistent and hard to understand, with limited visibility into provider credentialing, sanctions, and improved tracking of rendering personnel. Healthcare FWA harms patients, it undermines legitimate providers, it drains taxpayer resources, and increasingly funds sophisticated criminal networks. With stronger policy, better technology, and enhanced collaboration, we can significantly reduce the waste and protect the integrity of our healthcare system.